we divide the drugs into acute versus chronic gout options. For acute treatment, NSAIDs are the most popular drugs. They're the initial choice for acute gout management. Colchicine or intra-articular steroids can be considered as alternatives. Since we've previously discussed NSAIDs, let's now focus our attention on colchicine. This is a drug that inhibits microtubular polymerization. It's a microtubule inhibitor. And you'll notice on the right side of my slide, I have listed for you several microtubule inhibitors. Colchicine, we have 3 cancer drugs, vincristine, vinblastine, paclitaxel, and also the antifungal griseofulvin. These are all microtubule inhibitors. What if you got this question? What is it specifically that a microtubule inhibitor binds to? These drugs all bind to tubulin. Tubulin is a monomer. And if the question says, what reaction do these drugs inhibit? Most of them are going to inhibit tubular polymerization. Basically, that is the stacking of tubulin monomers. But there's one drug that's different from the others. There's one out of these 5 that doesn't inhibit polymerization. It actually blocks depolymerization. It's the drug paclitaxel. Paclitaxel is the one microtubule inhibitor that's different. This drug allows the microtubules to form a spindle. You actually can polymerize in the presence of paclitaxel. But this drug causes overly stable microtubules that cannot depolymerize. So 4 out of the 5 block you from forming the spindle in the first place. Paclitaxel prevents you from breaking it down. When it comes to colchicine, as you might expect from a microtubule inhibitor, it might cause some bone marrow suppression. Because of that action on inhibiting microtubule formation, that can certainly affect your bone marrow. Strategies for chronic gout involve targeting uric acid. The 2 drugs on this slide, allopurinol and febuxostat, are inhibitors of xanthine oxidase. By blocking this enzyme, you're going to decrease uric acid production, a very, very popular strategy for preventing gout attacks. Also, these drugs can be useful in cancer chemotherapy and radiation. We'll discuss this in an upcoming slide, but certainly in cancer chemotherapy and radiation, you're going to kill cells, perhaps also releasing uric acid. Side effects from these drugs, rash or hypoxanthine stones related to the mechanism of action, which again we'll see on another slide. And also the drug interaction with 6-mercaptopurine we're going to discuss. This figure does a nice job of illustrating how allopurinol and febuxostat are going to inhibit xanthine oxidase. And the action of these drugs is going to cause the accumulation of hypoxanthine. But importantly, we're going to stop the production of uric acid, and that's the most important strategy in treating chronic gout. Make sure you know the interaction between allopurinol and 6-mercaptopurine. When you go through this diagram, you see that 6-mercaptopurine, which is one of our cancer chemotherapy drugs, is actually a prodrug. It has to be converted to its active form by the enzyme HGPRT. Now, if you've been studying your material, I bet you cannot look at that enzyme without immediately thinking about Lesch-Nyhan disease. That's right. So if you have Lesch-Nyhan, not only are you eating your fingers and eating your face, but you actually can't activate the drug 6-MP if you lack this enzyme. But let's say you have it. HGPRT converts 6-mercaptopurine to its active form. Here's the important part for us. The metabolism of 6-MP involves xanthine oxidase. Xanthine oxidase is going to convert 6-MP into its inactive form. If you're taking allopurinol at the same time, you're blocking xanthine oxidase, and that causes an accumulation of 6-MP. In patients who are taking both of these drugs, we have to lower the dose of 6-mercaptopurine in order to avoid significant toxicity. Again, this could be happening in a cancer chemotherapy patient because allopurinol can be useful to inhibit uric acid production. You might also notice another drug on this slide, the drug azathioprine, which is used as an immunosuppressant. Turns out that azathioprine turns into 6-mercaptopurine and follows this same pathway. So allopurinol would also increase the plasma levels of azathioprine and require a dosage adjustment. If you're asking the question, does febuxostat have the same interaction? We've not really studied that property yet, but certainly you could predict that because it's a xanthine oxidase inhibitor, you would also see an interaction with 6-MP and azathioprine. In the margin is a clinical correlate on the drug rasburicase. This drug is a recombinant urate oxidase enzyme for the prevention of tumor lysis syndrome. In fact, what this drug can do is it can rapidly reduce serum uric acid levels because it can break down existing uric acid. The name says it all. If you look at the name rasburicase, in the middle of its name it says uric ACE. It's going to break down uric acid, which is a different action from allopurinol and febuxostat, which simply blocked uric acid formation. If you think about tumor lysis syndrome, when you're using cancer chemotherapy to kill cells, especially, let's say, in the treatment of leukemias, when you break down those cells and you release uric acid, that can produce a syndrome known as tumor lysis syndrome. The choice of using either rasburicase or a drug like allopurinol comes down to what does their uric acid level look like prior to starting chemotherapy. Patients who have normal uric acid levels before starting chemotherapy can be started on allopurinol to prevent tumor lysis syndrome. On the other hand, before chemotherapy, if your patient has a high level of uric acid, we most often will start them on rasburicase. So go ahead and break down the existing uric acid to help prevent tumor lysis syndrome when we start chemotherapy. Another option for chronic gout prophylaxis is to use the drug pegloticase. This is a recombinant urate oxidase enzyme, very similar to rasburicase that we just covered. It metabolizes uric acid to allantoin to reduce plasma uric acid levels. Watch out for the side effects of anaphylaxis or possible urticaria when taking this drug. Our final drug for chronic gout prophylaxis is probenecid. This is a drug that inhibits the proximal tubular reabsorption of uric acid, so its site of action is in the kidney. It doesn't work if you have low GFRs, defined as being less than 50 mils per minute. As we've seen in our text earlier, probenecid can interact with a number of weak acid drugs, including penicillins, cephalosporins, and fluoroquinolones. Probenecid inhibits the secretion of these drugs, which means the plasma level of your antibiotic is going to be increased.